as they go through the reproductive stage, what are the challenges they face in different stages, including since the start of the period, they start having catamenial epilepsy, some of them, and then they have challenges with contraception, which one to choose, how that affect their seizures, their medications. We're also going to talk about reproductive and sexual dysfunction that happen in women. And also most challenging thing is the pregnancy and lactation, how do we manage the anti-seizure medications and epilepsy itself. And menopause related issue, including bone health, mental health, other aspect. I will start with catamenic epilepsy, but before that, we will talk a little bit about the definition of epilepsy for a quick review. The International League Against Epilepsy proposed the definition as at least two unprovoked seizures occurring more than 24 hours apart, and one unprovoked seizures, or if it's called like reflex epilepsy or something like that, then that just one, along with similar recurrence risk of 60% if you have some sort of MRI finding or EEG finding, which are suggestive of higher risk. Or epilepsy is also defined when you have first time and the seizure started, you already have an epilepsy syndrome diagnosis, like some childhood epilepsy, then you really don't need to wait for two unprovoked seizures. One seizure with epilepsy syndrome diagnosis is enough for the epilepsy diagnosis, which tells us about the lifelong risk of having seizures for that person. So now women with epilepsy, they face, as I say, different challenges throughout their lifespan due to the seizure itself, which are being affected by the female hormone, as well as the anti-epileptic seizure medications, which also being affected by their metabolism are being affected by the female hormones. So awareness of this gender-specific issues and implementation of this effective intervention, this is going to significantly improve the quality of life. A lot of the women are not very aware of that. If we make this awareness, there will be a big changes. Now, epidemiology, although like sex ratio in the epilepsy is kind of like not fully established, but there are certain epilepsy which are a little bit gender difference or prevalence a little bit higher on one versus the other one. For example, the idiopathic generalized epilepsy and childhood absent epilepsy, those are a little bit more common, 2 to 5 times more common in the girls than the boys. And same thing with juvenile myoclonic epilepsy. It is also reported 1.5 times a little bit more common in women than men. Now, well, let's start with catamenial epilepsy. So catamenial epilepsy refer to exacerbation of seizure during different phases of menstrual cycle in women with pre-existing epilepsy. Now, before we move forward, I would like to say, when we talk about each of the segment, if you have any question, please send messages in the box. At the end of the catamenial epilepsy, I'm more than happy to answer any questions from, from our other audiences, our moderator, anybody who has questions, I'm happy to answer those. So let's start with catamenial epilepsy, and after that, we get a few minutes to answer those questions. Now, catamenial epilepsy, how common it is, surprisingly very common, just because people are not aware or physicians are not asking this question in a regular basis. Patients are not aware of this and they cannot tell you the correct data. But about 1/3 to half of the women with epilepsy actually has catamenial epilepsy. When I see patients in the clinic, if it's a woman, I have my own checklist of questions that I ask them. And one of the questions is, do you see any relationship of your seizures with your periods? If they can directly tell you, then I try to categorize. If they cannot tell, then I again try to see their regular menstrual cycle pattern. I ask them to make a diary of the regular cycle and the seizures when it's happening, and I try to correlate the the menses with that period, and I do that on the next visit, and that help you to diagnose the catamenial epilepsy. That way you can choose certain anti-epileptic drug and also some hormonal therapies for them. Overall, 2.5 times they are more likely to have menstrual disorder also, on the other hand, than women with other in general population. So not only that the period is affecting the seizures, but also they also have likelihood of having some sort of menstrual disorder with too. So seizure, what it does, it exacerbate, the anovulatory cycle a little bit more than the ovulatory cycle. There are research done on that, and it's well established. And the occurrence of the seizure during the anovulatory cycle is actually a little bit more than the ovulatory cycle itself. And that makes it more challenging because usually women with anovulatory cycle would have irregular period, and to find out that correlation of seizure is really challenging. Additionally, anovulatory cycle, as I say, it's associated with non-menstrual phases of the seizure disorder. We'll talk about different stages of catamenial epilepsy. Now, the occurrence of changes in estrogen and progesterone level is thought to be the key factor in catamenic epilepsy. They think progesterone is actually an anticonvulsant or protective hormone. On the other hand, estrogen is proconvulsant, which means it causes more seizures. I often tell my patients, E for estrogen, E for your enemy for women, because it causes more seizures, and P for progesterone, P for protection from seizures. Now, menstrual cycle, it's a different classification of menstrual cycle. Like, if we think about menstrual cycle, they have the menstrual phase, which start anywhere between day 25 or day 28, and then it start up to day 3 or 5 of the next cycle. The follicular phase is the day 4 to day 10, depending on the patient. The ovulatory phase is 11 to 16. Luteal phase is 17 to the 3rd day of the next cycle. Then catamenial epilepsy is actually categorized as C1, C2, C3. C1 is perimenstrual pattern, where what happen in this case is they have more seizures from day 25 of the first cycle to the day 3, mean when they have the periods, or just 1 or 2 days before the periods. Then C2 is peri-ovulatory. That's mean before the ovulation or the mid-cycle. So you'll see patient will having more seizures around day 10 to 14, which is the time for ovulation. Then C3 pattern is the luteal pattern, where you will see after the ovulation, anytime like day 17 up to the first cycle of the day 3, they can have, before they start the follicular phase, they get those seizures a little bit higher. And once the period is started, kind of like decrease. Now, C1 and C3 are associated with decreased progesterone levels, but C2 sees like increase the level of estrogen. That's how they say it. It's basically the balance between the progesterone and estrogen is off. Either decreasing progesterone can also cause, or increased level of estrogen. Now, the frequency of generalized convulsive seizures was found to be higher in anovulatory cycle, as I mentioned, compared to the ovulatory cycle, and it is also because of the estradiol and progesterone ratio as altered in this type of cases. Now, how do we manage catamenial epilepsy once we diagnose? As I say, we take our time to talk about this and try to find out the if it's catamenial epilepsy or not, and how does it help us? So if we can categorize if it is C1, C2, or C3, instead of increasing the medication for the patient from 1 to directly 2, or from 2 to 3, what you can do beside the regular medication, like 1 or 2, whatever the patient is already on, you can give an intermittent another medication just around the time when patient has more risk of seizures. The preferred drug of choice is actually benzo, one of the benzos, which is clobazam. It is shown in different studies in randomized controlled trial, which is one of them is like a Philly and the Gibstone in 1984. They find out that this is very helpful around the time of the seizure increase. And there was alternative therapy which has been also proposed is acetazolamide, which you can also use if you don't have, patient doesn't have access to clobazam, or it's kind of expensive for them. And another one is progesterone hormonal therapy itself, which can also be used usually if you, I mean, the way we practice here, if we wanted to give progesterone therapy, we send them to OBGYN and they give the patient progesterone therapies around like kind of like a birth control pattern and also a little bit higher around the whenever the seizure occurs. Now, the result from a recent randomized control trial, which is done on the Hargis in 2012, it shows that women with epilepsy who present with C1 catamenic seizure pattern have benefit from progesterone treatment. And another study done on the French too. So C1 pattern may respond a little bit more to progesterone therapy than the other one. Okay, so I'm done giving you the highlights of the catamenic epilepsy. I'm more than happy to answer any question on that topic. I'll keep the chat box open for 2 minutes just to see if there's any other question, or if you want to just ask me directly, you can turn on your microphone and ask the question about catamenic epilepsy, diagnosis, management. I know Dr. Sultana is here from Dhaka. If she wants to share her perspective, how frequently, if a patient has been referred to her for progesterone therapy, can you give us some perspective, Dr. Sultana?
Yes, good evening. Thank you for your nice presentation. Catamania seizure epilepsy is we face very few patients because most of the cases patient with only with epilepsy, they visited to neurologist in our country, and we also refer them to the neurologist. If they face any reproductive problem or irregularities in menstruation, actually, then they will visit it to us. And we have seen that the patient with PCOS, some patient, the catamenial epilepsy, they also have PCOS and irregular menstruation. Probably in PCOS patient, there is increased estrogen, which may influence the catamenial epilepsy, probably. And is there any role of OCP to treat this catamenial epilepsy?
Yeah, thank you. Yeah, you're right. Many of those patients has PCOS because of anovulatory cycle, because seizure actually interrupt the pituitary our cycle, and that's the thought that why they have more anovulatory cycle. But now here is the challenge for PCOS. We know that one of the therapies OCP that the OBGYN often try. From our perspective, like when I see patients, I recommend them not to take as OCP because not for PCOS particularly, any patients, we recommend not to take OCP because oral contraceptive pill actually has synthetic estrogen. And it has been shown in the study, synthetic estrogen actually can increase the seizures more than the body's natural estrogen. So I don't know, what will be the challenge, when you have a patient with PCOS, how would you balance the situation? But I don't know if in PCOS only giving estrogen will, progesterone will be some options, or this is not something we try. Hello, Dr. Sultana, do you ever try only progesterone for PCOS, or it's not an option?
Yes, we have to regulate the cycle. We use progesterone in PCOS patient, also weight reduction. And during treatment of catamenial epilepsy with PCOS, those are overweight, we will try to avoid those AED which increase the weight more.
Yeah, try to avoid. Yeah, and also those, we'll talk about those. Those also certainly have more effect on, effect on other problems too, like pregnancy. I see there are questions here on the box. Dr. Sanjukta Chaudhary mentioned, and how do a patient with catamenic epilepsy behave when she becomes pregnant? Yes, regarding what happened to the seizure once they get pregnant, we'll talk about it in a moment. When we talk about pregnancy, we'll say that it's actually not that bad the way we think. Most of the patients actually, they do better when they get pregnant, and we'll talk about it. Next question is, what would be the dose of progesterone in catamenic epilepsy? I actually, we here, the way we practice, we don't directly give progesterone, but maybe we can ask Dr. Sultana if she has experience on giving progesterone to someone, or how do you?
Yes, we can give medroxyprogesterone or natural macronized progesterone. If we give medroxyprogesterone, we can prescribe it from day 10 to day 26, 5 milligram twice daily, or we can give natural macronized progesterone, 200 milligram, 12 hourly from day 10 to day 26.
So, Dr. Sultana, you don't classify, like there is that classification of C1, C2, which is recommended. Like, I don't know the doses, but usually I provide this information to the OBGYN that patient has C1 category of catamenic epilepsy or C2, C3, where I kind of like give them information that patient had during these days of the period. And then as far as I know, they gave only progesterone for that time. But I don't know if in Dhaka, do they use this classification of catamenial epilepsy?
Yes, we use this classification. And so when there is decreased progesterone, in that case, we give progesterone, but when there is increased estrogen level, like increased estrogen level like in C2, then we give clobazam.
I see. Yes, right. So the benefit of progesterone is actually mainly proven around the C3 and sometime on C1. Yeah, thank you, Dr. Sultana, for answering that question.
Thank you.
Okay, so we'll move to the next part. I know some of the questions has been unanswered, but I will get back to those questions as we move forward. Next one is reproductive and sexual dysfunction in women. So impact of anti-epileptic drug and epilepsy both kind of contributed in the reproductive health. One of the things, as Dr. Sultana was mentioned, that many of her patients that she has PCOS. And as I mentioned, that because of the seizure interrupt our pituitary and reproductive or ovarian cycle, that's the reason why they have this irregularity. On top of that, when you have the PCOS, on those animal cycle, there's certain type of anti-epileptic drug you cannot use because some of the anti-epileptic drug actually may worsen the PCOS, like valproic acid was very well known. It causes PCOS-like syndrome, so you would like to avoid those. Now, the frequency of this menstrual disorder, it's particularly elevated among the women with high seizure frequency, but in those groups, usually those who are on polytherapies. Seizure and sexual dysfunction is also something. Many of those women who suffer or struggle with a lot of seizure, they say they do have the prevalence, like they do have a lot of sexual problem, including desire, depression, poor control of the seizures, all those, and their sexual life being also impacted with the frequency of the seizures. Lamotrigine is associated with less sexual side effect compared to any other seizure medication. So when we choose the medications, this is something we need to consider too. Now, this was a very short one, and another one I will talk about, and then we can go for the question and answer session again. Next thing is contraceptive and anti-epileptic drug. So when you are managing a patient with in reproductive age, as a neurologist, you have to think about a lot of things, that they are going to be pregnant. what seizure medications you would like to choose for them, because you don't want to change the seizure meds when they get pregnant. You actually have to plan it before, when they are not pregnant, basically when they come to you. And then you also have to choose or guide them to choose the correct contraceptives, because you have to tell them, this is something I would like you to discuss with your OBGYN, because this is how it can be affected with this seizure meds and the contraceptive or contraceptive itself. So it's a very complex and multi-directional interaction, but we also have to simplify the information to the patient so that they can get the gist of this whole thing. So one of the things is the anti-epileptic drug and contraceptive. So one of the drugs that we like for reproductive age is actually lamotrigine, because lamotrigine doesn't have too much of fetal side effect when a woman gets pregnant. But on the other hand, lamotrigine is actually very highly metabolized by the estrogen that we have on the OCP, oral contraceptive pill. So someone who is taking OCP and you give lamotrigine to them, thinking that at one point they will get pregnant, it will be better for them, that will be one of the issues. So you have to talk to them that you may need higher dose of lamotrigine if you are on OCP. And not only that, even without lamotrigine, oral contraceptive pill, as I was mentioning to Dr. Sultana itself, we don't recommend that much, because the synthetic estrogen component of OCP is actually put you at higher risk of having seizures than your natural estrogen itself. So it's a challenge. You wanted to talk to the patient their own, and that also explain them. This is the way to explain them about the catamenic epilepsy too. So you want them to avoid as much estrogen as possible, and you want them to choose an contraceptive which doesn't have estrogen. There are a lot of other options like copper T. They have different type of IUD option with only progesterone. They have like the intradermal progesterone. We do have some here in the United States, like levonorgestrone. A lot of my patients are on that. It's an IM therapy they have, and that works for them. Now, as I was mentioning, some of the anti-epileptic drug, being affected by contraceptive. On the other hand, contraceptive sometimes also get affected by the anti-epileptic drug, and you have to make sure you remind that to the patient, because they may be not ready to be pregnant, but because of the seizure meds and the OCP, it's not going to work. So the enzyme inducer seizure meds, especially carbamazepine, oxcarbazepine, topiramate, phenobarbital, dilantin, those have like a cytochrome P3A4 proper like inducer property, and that's what also induce the metabolism of OCP itself, and patient can be pregnant before they're ready for that. Yeah, no clinical interaction has been documented for valproic acid, levetiracetam, Keppra, ethosuxanamide, pregabalin, gabapentin, vigabatrin, tigabalin, benzo, and any other form of OCP. But also, when you choose from this list of what doesn't affect with OCP, you have to make sure that OCP itself can make seizures worse, and also you may want to avoid that. And the other thing is, you also wanted to choose something which is safe for patient, not like valproic acid, because if these patients get pregnant and someone is on valproic acid, this is something you don't want for your patients. So the effect of contraceptive of AD is, as I mentioned, the most affected one is actually lamotrigine, and we choose lamotrigine a lot for our reproductive age female. Now the recommendations, so what should we do in this type of cases? As I mentioned, you try to recommend them to choose one of the progesterone containing one, which is like metroxyprogesterone, depot injection. They have levonorgestrone releasing IUD, copper containing IUDs, and maybe there are many different options with OBGYN can guide them. So before I move to the next topic, I'll give 2 minutes for any questions or anything from our audience or our other faculties here. So, Dr. Sultana, when you see women, pregnant women, What's the most common seizure medications you see the neurologists are prescribing there?
Only now we see that is carbamazepine, lamotrigine, and levetiracetam.
Okay, yeah. And I mean,
Commonly, patient came with this medication to us.
yeah, that's good. I mean, levetiracetam is one of the safest one we
Yes.
have. Lamotrigine is also another safest one, though they say sometimes it can cause cleft lip, cleft palate, but data is not very strong. Carbamazepine is also, I mean, sometimes it say it can cause oligomenorrhea, but it's also something they can choose. Yeah, if the other medications doesn't is not an option for the patient. But yeah, those are the most common we also use here.
Oxcarbazepine is also, we
Yeah,
get
same,
oxcarbazepine.
right. Yeah, in many cases, actually choosing off-carb is way better than carbamazepine because you get less side effect overall, not related to pregnancy, but just patient related, like hyponatremia is less common, blood count disorders are less common with oxcarbazepine. I'm not sure about the expenses, but it's a little bit expensive here, and sometimes insurance company have a little hard time. There's a question for Dr. Esmat Manan. What about the low dose of OCP? I personally do not know about the OCP doses too much. I think there are different type of options that can be provided. I heard, but I don't have a great knowledge on it. But any type of synthetic estrogen increase your chances of seizure, and I haven't heard about any research on that. But I think it's not that OCP is out of the table. You cannot use it. It's just like you have to provide the information to the patient. There is high chances of interaction. That OCP, number one, if you give low dose, I think there are more chances of pregnancy. I would assume. I don't know what's the definition of low dose, but there should be more chances of failure. On the other hand, if the seizure is inducer, then you have like complete chances of that OCP is not going to work. And then also the other thing is you also have to provide the information to the patient that you have a slight increased risk of seizure. There's no harm in trying and see, because everybody's body is different. Their hormonal response is going to be different. But I think if you have no other options, this may be something you can give it a try and see. But there's no specific, I'm not aware of any research or anything done on this to compare, low dose, because the general tendency is just to avoid OCP for them.
I want to answer this question.
Yeah. Yes, please.
Those women who have no children, who have not delivered, and they want contraceptive advice, in this case, we avoid IUCD, copper containing or levonorgestrel containing IUCD, and in most of the case, we give them OCP, oral contraceptive pill. But in this case, if the lady taking enzyme-inducing AED, anti-epileptic drug, then we have to give OCP, estrogen in high dose. High dose OCP we have to prescribe.
The other way
along with she also used the barrier method. Barrier method has very high failure rate. So we have to ensure them an effective contraceptive. So we can give OCP and along with barrier method in OCP in high dose. But if the lady has delivered baby, they have paras lady, then we prefer them for copper containing IUCD or levonorgestrel containing IUCD is better, and better to avoid OCP in those cases. Thank you.
Thank you. Yes. So, as Dr. Sultana mentioned, and I was trying to explain that there will be actually higher chances of failure if you give low dose, especially people with inducer. So you have to be more mindful about the seizure meds, and you may want to give them higher. But when you are giving the higher concentration of OCP, it's kind of like also a problem. You may end up giving more seizures. Now, the one question is what type of anti-epileptic drug is preferred in childbearing age? Actually, Dr. Sultana, we were just discussing from, what most commonly used in DACA and what do we use. When I have a patient with childbearing age, I usually like to start with levetiracetam, which is Keppra, we call it, or in Bangladesh, I think they have Irata. That's the same drug. This is one of the drug, but you have to ask the patient if they have any psychiatric history, bipolar, depression, or you may get this challenge. Many patients underdiagnosed in Bangladesh, they don't really take care of their mental health. So you have to make sure, because levetiracetam has significant effect on their mental health. They may start feeling depressed or anxious. Most common one that my patients report, almost everybody, is I feel like I'm short tempered to my family members. So levetiracetam makes a little bit of psychiatric issue. You definitely don't want to give it to someone who has history or thoughts of like suicidal, homicidal ideation. So that's out of the table when you have those problems. And the second thing I choose is lamotrigine, which has actually the benefit the other way around. So it is actually a mood stabilizer. So somebody who has psychiatric history or questionable depression, you can see after talking to them, then you may want to give lamotrigine, because that will actually benefit from two sides. And one of the challenges, if someone is having too many seizures when they come to you, you're kind of like, you may want to start with levetiracetam first, because lamotrigine, it takes a pretty long time to take higher dose. I'm not sure about the practice in Dhaka, but you have to think about. I remember from my internship when I was doing training in Dhaka, and I remember we used to see the Stevens-Johnson syndrome from lamotrigine. This is one of the biggest side effects we can think of, because it's literally causes burn in the body. So you have to be aware of that. And the way we prevent that, or the incidents are lower actually here in US, one of the things I learned is you have to go very slow in lamotrigine. When you go very slow, you have a higher chance the patient will not develop the side effects. So on the other hand, you cannot go higher, but that will increase the tolerance of the patient. So the way I do for lamotrigine is I give them 25 every week. And every week you increase by 25. So to make it 100 milligram twice a day, which is your basic dose, it will take you 8 weeks or 2 months. And then from that, you can go 125, 150, up to 200. I have patients who are on 300 twice a day. It's a very good medication with very minimum side effect, but you have to make sure the patient can tolerate well, and you have to go very slowly. This is one of the slowest medication that I know, other than like the recent cenobamate, but this is one of the slowest medication we go for our seizure patients. So you really cannot give it to someone who has a lot of seizure. But this is another preferred drug in childbearing age. And also remember, it is very, OCP, increase the metabolism. I think there is a question from Dr. Rubel. If the lamotrigine dose at lab measurement is not possible, can we do it blindly? It's just if you don't have it available, I think you can just do it looking at the clinical response. I cannot think of the situation. We always have the lab available, but I would think, like, if you don't have the lab, then your next best bet will be a clinical response. So what you can do, you can start with the minimum one, like 25, and increase. And once you reach 100 twice a day with the same OCP, whatever they are on, you watch them for 2 months, ask them to come back with the seizure diary, see how frequently they're having seizures. If it is still frequent, you're not happy, go to 125, then 150, and see what is the dose where patient had optimum seizure, management with, whatever other medication, like without the dose. I think that's another best way to do. And I think Dr. Rubel's question was also, without the label, do you measure? Actually, for lamotrigine, I don't do the levels all the time. For male patients, I just treat them clinically. I start them on lamotrigine, and if they're having seizures, I keep on going higher until I'm happy. For women, I need the lamotrigine level because the OCP is going to interact with the lamotrigine and I have to go higher. So I don't know if that answered your question. Then Dr. Fatima, Fatima has a question. If you give high dose of OCP, then how will you adjust the AD? It's actually, you don't adjust AED mostly. It's actually you adjust the OCP. Seizure medications, you want to keep it the same, because if you adjust it too much, it is going to cause side effect in different system, and also if you decrease it, it's going to cause seizures. So you keep the AED, but what the AED does is AED induce the OCP metabolism. So what will happen is your OCP will be cleared by the AED. AD is not being affected by OCP, it's the other way around. So that's why Dr. Sultana was saying sometimes they give high dose of OCP to those patients. That way, even with the metabolism, they sustain the proper amount of estrogen, progesterone that she requires for the patient to have a birth control. I don't know if, yeah, okay, sounds good. So it's the other way around. The only drug actually where OCP increase the metabolism of the drug is lamotrigine, and that one you can treat patients clinically if you don't have the lab available. Okay. Now, I'm not an OBGYN, but here, the way, or also the contraceptive that we are using, OCP and other, are not the same chemical that we are using in different countries. But currently the medroxyprogesterone depot injection that they have, it has pretty much same type of birth control property as OCP. That's the documented say in US, but I cannot really speak for about the medroxyprogesterone available there. So our patients with that, actually they do very well. The company they have is here, it's actually not medroxyprogesterone, it's actually levonorgestrel, one of the one which they use intramuscularly, and pretty good as OCP. So I barely have any patients on OCP. And then Dr. Ismat Manan, one more question. Is there any study regarding the fact and whether it is raised estrogen or increased sensitivity to estrogen that precipitated epilepsy? Raised estrogen or increased estrogen? What the studies say, the biochemical studies they do on rat and other, is the high level of synthetic estrogen. It's not they're very sensitive to estrogen. It's more like, if there is higher level, and mostly if this is not natural one, like a synthetic one, they are more sensitive to those synthetic estrogen. And now they are not sure about the exact chemical component, which one is the one. And the day they can find, I think they can modify those OCP and other contraceptive a little bit more. Okay.
I want to say about medroxyprogesterone acetate. It is also available in our country, and the 150 milligram IM, routinely we give it at 12 weeks interval. But in case of epilepsy, we have to give it 10 weeks interval. This is the difference. Instead of 12 weeks, we prescribe at 10 weeks interval and 150 milligram intramuscularly. So we can avoid OCP, and we can use these safer contraceptives for those patients.
So Dr. Sultana, do they have the levonorgestrel, subcutaneous one in Bangladesh?
Levonorgestrel implant is available, but levonorgestrel IUCD is not commonly available. We have to purchase this from foreign country. So levonorgestrel IUCD is not available, but copper IUCD is available here.
And also the one that I see, it was not in the journal where I prepared my article from, but the one that I see for my patients are there on levonorgestrel subcutaneous one. And I saw, many of the patients are there. I didn't hear about too much failure. I looked at that, and they said it's very good, effective, as equal to almost like LCP, levonorgestrel one. This is not, was not included in the articles where I present my presentation from. Let's see if there is any more question. I think we're done answering the question. If you give, okay, let's move on to the next, very important topic: pregnancy and lactation, and how do we manage that? Now, here is the good news. As I was mentioning to one of the doctors before, that I'll answer this question. Though we are very scared, someone got pregnant when they have epilepsy history, but the good news is most of the patient actually they do better. It's a fear among many providers that or physicians that it will get worse. Actually, they do good better. Especially the patients who had no seizure before they, at least a year before their pregnancy, they do fantastic. So it's very important when you see a patient with reproductive age, you want it to be as aggressive as possible and try to get a very good control before even they think about pregnancy. I had patients like that where I saw them for first time, I counseled them about that, and they called me a week or so. I have like counseled them, and I started changing their medication to a safe one, and they call me within a week or two. Oh, my pregnancy test is positive. I said, oh, okay. So, there will be some challenges, and many of the pregnancies are actually not planned. Um, you know, there is contraceptive failure and many other issues. And so you want to always, whenever you see a reproductive age female, you always want they can be pregnant anytime. So you have to choose your battle from the very beginning. And if you can have a better control, you will have a better outcome during pregnancy. So in the European and International Registry in Anti-Epileptic Drug in Pregnancy, they saw 64% of the women has no change in their seizure control during pregnancy, especially first trimester or up to the second trimester. And 93% of women actually they remain seizure free, which is very good number. But the women who don't have a good control or got bad, it's the challenge, because now you're not only protecting the women, but you also have to think about the baby. It's a hard, thing to do. Concerns about increased seizures for obstetric complication with those women, they're not very supported. Like, for example, somebody who has seizure, do they have more chances of having C-section? Do they have more chances of having obstetric complications, like different thing, premature ruptures and other things? Those are not really proven, but definitely during pregnancy, there are effect on the fetus that has been, that's what you have to worry about. Now, impact of seizure during pregnancy. Case report of both generalized and complex partial seizures occurring during labor has been associated with deceleration of the heart rate, suggestive of fetal hypoxia, and with prolonged uterine contraction. That's a problem that they face, people who were having seizures and they're in the labor, certainly because, your body hormones are activated. You also become tachycardic and it's hypoxic, same as your baby. So seizures resulting in fall can cause direct trauma. That's a problem, and that can cause with different obstetric complication. They can have gravid uterus, or they can have bleeding, premature rupture because of the fall, or fetal death even. So those you have to be aware of. Abruptio placenta has been reported, which is not really an obstetric complication, more like when they're pregnant, they had those issues. And even with mild traumatic injuries, or 50% with a blunt trauma during pregnancy. So this is another one pretty common, which can cause fetal and bad, maternal fetal outcome. Now, the cause why women, act certain way during pregnancy, because the circulating level of a steroid is different when they get pregnant. There is increased blood volume and cardiac output. So you are diluting your seizure medications, right? Oftentimes, pregnant women need higher doses of seizure medicine than before when they're not pregnant. So we have to have a data and to know how to go up on that. They have increased glomerular filtration rate in pregnancy. They have postural hypotension. So the drug are not well distributed everywhere, not going to the brain where they're supposed to go. They have dilutional anemia. They have increased metabolic rate, insulin resistance, and they have different type of pharmacokinetic profile of anti-epileptic drug. Like the metabolism is actually increased because during pregnancy, you have higher level of estrogen, which are secreting from placenta, which also going to metabolize the different anti-epileptic, though synthetic are worse. But even when the normal estrogen, the own bodies are also after a critical level are too high, that also going to affect, just like how women are being affected by catamenic epilepsy. Now, how do you monitor those patients? That's the question here. And I don't think there's a proper guideline, at least not in the United States, how to do that. But we have a consensus how we would like to do that. In our institute, we have women, pregnant women come to a dedicated seizure clinic where we see them more frequently. So you need to have a pre-pregnancy level, and for the women, if it's possible, but many times the women come to you when they're just pregnant. So the pre-pregnancy level will guide you to know what's the level for that patient to control seizures. So let's say somebody is on levetiracetam, and it has a huge lab value, like 50 to 100, and now you don't know where that patient is, right? So before pregnancy, if you have a level that, oh, this patient is well controlled on 77, so you really don't have to shoot for 100. So you try to be around 77, like 75, 79, something like that. So you need a pre-pregnancy level to know what was controlling their seizure. So, and then when they get pregnant, you will see, not in the first trimester too much, but on the second and third trimester, when the placenta is full developed, there are more estrogen, you'll see there is sharp decline on their Capra or the levetiracetam level. So you have to, and it's for everybody is different. Everybody has different estrogen or placenta, and it's going to be very different. And you have to increase to maintain the level, whatever was working for them. So it's not about the lab value. You can think, oh, my patient was therapeutic at 56. Why? That patient had seizure then. No, it's not about being the lab value of therapeutic. It's what's their value of being therapeutic. So you have to know what was their value to have seizure control before pregnancy. And if you don't have the data available, then use the one from the first trimester, because that's also pretty close. You don't have that much of estrogen, and then you can be around that period. So in first trimester, what we do is we get the estrogen, the drug level right away. And then we try to do it every month. And then in second trimester also, we try to do it every month. But if we see too much decline, then you can do every 2 weeks. And then you adjust accordingly. And how much to adjust for how much fall, it's just like how much is falling or having seizures, you just go a lot according to that. And on third trimester, not on 8 months, but at the end of the pregnancy, at least, especially the last 6 to 8 weeks, you have to do every weekly, the monitor the level. And once they deliver, they lost the placenta, they sharply declined that estrogen level. So you don't want that toxic seizure medication level for them, because now they're also lactating the baby, and you don't want the baby to get that much of anti-seizure medication. So you have to properly decrease it to a level which is safe for mom and the baby. So what you do is basically you're going to check the level every single day, and you're going to decrease the level slowly to a level to maintain. Usually you do it takes you a week to adjust. And after the delivery, you see the patient every weekly for first 4 weeks, and then kind of like once a month. And then after the first 3 months, you kind of like can decrease once the level is very stable. So that's how we monitor here. It's very different from institutions to institution. It's very different type of monitoring from physician to physician. As I say, we don't have any guideline here, but this is what we do here from the consensus what we have for women with epilepsy in the United States. So now you have to think about when they're pregnant, you have to think about teratogenicity. So you don't want to give certain anti-epileptic drugs which are bad for the babies. And the safest one, as I mentioned here, going to be levetiracetam, lamotrigine. Sometimes they use carbamazepine or versus oxcarbamazepine, which is okay. Then on pimerinosol, sometimes use, but those are the ones can also decrease the, cause oligohydramnion or decrease the fluid around the babies. And then clonazepam is another one you can use, kind of like a benzo. Then you have gabapentin as an option. The teratogenicity of certain seizure medication, patients are very aware and they just don't want to take medication at all, but you have to counsel them Not all the seizure meds going to affect the baby. Actually, it's going to do good fit. It will benefit the baby because some seizure meds are going to control your seizures, which is very helpful for baby. And the modern one we have are really good. So other than this, the old one, just to be aware, because sometimes you'll have surprise and you will see somebody a third trimester or second trimester with those medications. And we see that all the time. They come from different part, like a little bit on the countryside and or villages. And then, you are in the middle of that situation. So they have phenytoin, valproic acid, carbamazepine, barbiturate, benzo, those are very high fetal. So Dilantin causes, or Dilantin or phenytoin or phosphonatoin, both of them, same side effect. They causes fetal hydramnion syndrome, congenital heart disease, facial cleft. Valproic is one of the most terrifying one you can think of. Before pregnancy causes PCOS type syndrome, and then during pregnancy, neural tube defect, craniofacial, skeletal, cardiovascular, cerebral defect, language problem. The way I counsel my patients are in reproductive age that before your test is positive, which is at 4 weeks or 5 weeks, like the best one will be 4 weeks, but mostly 5-6 weeks, your baby's brain already started developing. We really don't have enough time to change your medications when you will come. I would rather change your meds right now when you are in reproductive age, knowing the fact you are going to be pregnant in a few years or so. Even if someone say that I had 3-4 baby, I don't want to be pregnant, but we'll still keep them safe because many pregnancies are surprise. So we would like to keep them until they reach menopause. You don't want to give them valproic acid, but sometimes you'll see there are some patients who are on it. And then carbamazepine can also, there are data like neural tube defect, congenital heart disease, reduced growth, hypopituitasis, those, but not very common. And, I use sometimes oxcarbamazepine, but, it's kind of like a last resort for me. I start with levetiracetam, lamotrigine. If I cannot get it controlled, then I kind of like topiramate and then move to oxcarb. Then barbiturate one is really bad. Congenital heart defect, craniofacial defect, limb abnormality, growth deficit, all those benzodiazepam can cause like orofacial cleft. Lamotrigine, they say non-syndromic facial defect, like it's not part of the brain anomaly or anything. They can have like a little bit of facial cleft, but it's not, the data is not very strong. I had so many patients on lamotrigine who were pregnant. I never saw anybody having baby with facial cleft. Then teratogenicity. So the further recommendation into, as I say, preconceptional folic acid, preconceptional counseling of anti-epileptic chews, and also you can give preconceptional folic acid to them to prevent congenital malformation in newborn. Now, how much folic acid to give? So people who were pregnant and they are on older drugs, we used to, the study shows like 4 milligram of folic acids are good for them. So usually when someone get pregnant, if you look at their vitamins, the OBGYN recommendations are usually around 80, anywhere between 400 to 800 microgram. But we're giving them 4 milligram, which is like almost 5 times or 5 times higher than normal women's folic acid need during pregnancy. But now, what about the modern drug that we are using, right? For levetiracetam, lamotrigine, for years in US, we continue to give it. There is a recent, this year actually, there was a conference where they presented that this type of high folic acid for unnecessary folic acid for the newer drug actually can cause different type of problem, ADHD, autism, all those, and also cancer for baby. So we're reducing and we're not stepping back to reduce the folic acid need for the modern drugs. So if you nowadays, what should we do right now? So we don't have the exact data, but people who are on like levetiracetam or lamotrigine, like newer agent, we give them like 1 milligram. And we also counsel them. We used to use higher, but it has shown they have more cancer, baby cancer and all those risks. Okay. Now, lactation. So you can see like things are so dynamic, even here in the United States, UK, and international conferences. They're just talking about how to best manage the woman and the babies. It's a very challenging situation, and it's under a lot of investigations. Now I'll move to lactation, and after finishing that, I'll go and answer the questions that we have. So lactation is another challenge. Now you're done delivering the baby, you're going to breastfeed. You know, the breast milk is way better than the formula milk you have in the market, because with the breast milk, you're giving all the immunoglobulin to your babies. And you wanted to give that, you wanted to do this part for your baby. You have to carry the baby, and the mom wanted to do that for their baby at least for 6 months. Now, if they're taking anti-seizure meds, are they going to the baby, and how they're going to affect the baby? So, anti-seizure medication, they are going to go through the breast milk, not a very high amount. If you think about the placental transmission with the blood, it was pretty high. So your baby is used to with that, but it's still, you want it to decrease. So if you choose those modern drugs, you are going to titrate down to the pre-pregnancy dose as soon as you can. As I mentioned, after delivery, we do it every day to look at the decreased estrogen and the decreased drug level as soon as we can, and then we adjust and give the minimum medication they need. But also, it's very important for the women to have the drug, because how a woman with epilepsy can take care of the baby? They have to, we recommend there, don't give bath to them when you're all by yourself, or shower. It's hard for a mom, right? They try to do everything for their babies, but on the other hand, it's not safe for that mom, because if they ended up having seizure, they're going to injure that newborn, and it happens. So you always have to have a supervised. Then don't hold the baby walking around. A woman just deliver a baby, they cannot even have the freedom. So it's hard for them. Mostly we ask them to hold the babies when they're in the bed, just in case they have seizures. So it's hard on the patient. So you wanted to make sure your seizure is optimized with the minimum drug they need, so that none of them get affected. And it has been recommended to give vitamin K to the baby when they're born, right after they're born. And it's again the study done on the previous or old seizure medications. We really don't know about the new ones, how that affect vitamin K, because the previous older one were the enzyme inducer, which can decrease your levels of different vitamins from the liver metabolism. Okay, so when you get a pregnant women talk, it's a hard discussion. It's a long discussion with them. And after the deliver is the hardest part. Even before the delivered, counsel them. You have to be safe. You don't want it to give bath alone, shower alone to this baby. You want to hold them in the bed. You don't want to hold them when walking around with the baby, because we want to make sure your seizures are well controlled before you get more freedom. So it's hard for the mom, hard for a physician to counsel on those things. Now I can start and answering the questions. Let's see. Okay, so let's start. There's a long question here. I'm trying to see. Hold on. Okay. Dr. Kazi Janat mentioned that we know that sodium valproate is having highest teratogenic effect among all of the anti-seizure medications, and more safer drug are levetiracetam and lamotrigine during pregnancy. My question is that a woman suffering from juvenile myoclonics, she wants to become pregnant. She's treated with low dose of sodium for 600 with a good seizure control. What should be approach to consideration of anti-epileptic for least teratogenic effect for her? And around 600 milligrams per session. Consider to continue sodium valproate with low dose. Is it possible to give any recommendation support for low dose sodium valproate pregnant women suffering from JME? So, first of all, for juvenile myoclonic epilepsy, they had this research done on 3 drugs, and they find out what is the most effective drug or most tolerated. So there is valproic acid. You have option for lamotrigine. It is also very good for JME, and you have option for levetiracetam. Among all 3 of those, lamotrigine is actually the best or most tolerated medication for JME. So even for JME patients, when I see them in the clinic, this is the first drug I start with, lamotrigine. I don't jump into valproic acid for them. There are 33% of the cases with JME will have refractory JME. You may have to choose a second drug. Then your option will be adding lamotrigine with levetiracetam. And at the end, if I cannot control, then I add it as a third drug, but I never choose as a first drug because this is a very well-established study for JME that all of those three drugs are actually effective. Yes, valproic acid a little bit more effective, but it's the least tolerated drug among three of those because of the side effect that woman is going to suffer. Now, second thing that actually also come from your question is somebody is on 600. I assume you're trying to say 600 a day. There is a study shown that if the valproic acid level or drug that is being used is less than 800, or in some studies say 750 a day, then dose doesn't cause that much of teratogenicity like the higher doses. So this is one study they did. So if someone is on lower dose, but why use, I mean, if you have the option, if somebody's already on that, then you have nothing to do. But the thing is, why to use that drug, as a monotherapy when you have well-established studies showing that lamotrigine and levetiracetam works for them. JME, they did the back-to-back study on them. So, but if a patient already come to me with valproic acid, then I just talk to them, you're already on this drug. I would love to change you, but you already, you look at the level, like they're down with their second trimester, then you really don't have to change or anything. But you give them the option. If you want, I can change you to another drug, which is also safe, and very well effective during the JME situation. Yep. So, I mean, but if you have no other options, then lower dose, but usually not as a monotherapy. It's better to use the other tools before you go to valproic acid. Okay. Any other question on pregnancy and lactation? We can give a little bit more time to this topic. It's very important. Dr. Sultana,
Yes.
so, when you have the patients deliver in the unit, how frequently are they monitoring the neurologist, the seizure medications?
So for this type of patient, we will advise them to deliver in a well-equipped hospital where there is the labor can be monitored properly, and also the neonatal facilities are well adequate. And during this, we allow this patient for vaginal delivery. We can induce them as usual if there is no contraindication. And during the labor, we have to give them adequate labor analgesia. Like if the facility available, then epidural labor analgesia is better for them. We have to take care. So to avoid the dehydration, we have to maintain their nutrition and calories. We have to counsel them so they do not feel any stress, anxiety. Try to avoid them. So these are the risk factors which can provoke them for seizure. And we also encourage them to take the anti-epileptic drug. Do not avoid these drugs, and closely monitor the labor patient by using CTG to monitor the fetal condition. And if labor in second stage of labor, when to deliver the baby, if it is prolonged, we can use the assisted vaginal delivery to relieve the mother. And if there is a convulsion during the labor, we can use diazepam during that time. And if the seizure is prolonged, then or repeated, then we allow her for cesarean section if needed.
I see. Yeah, in my practice here, I have seen women I mean, I don't have to manage preeclampsia or eclampsia because those are managed by OBGYN here. But those are more common than somebody who has history of epilepsy and having seizures. Is this true for you, Dr. Sultana?
Yes.
Okay. So yeah, I mean, this is important to know, just because someone having seizure, we don't have to scare them that you're going to have seizures during pregnancy or delivery. Actually, as I say, the good news is they get better if they take seizure meds properly, follow with the neurologist, OBGYN during the pregnancy, compared to people who has other reason of having seizure, which is preeclampsia, eclampsia, which are not epilepsy. Those are seizure related to the pregnancy, and they have different causes. Those patients actually they don't do very good if the blood pressure and other things are not well controlled, and they have more labor, complications. There was one question, I think. Let's see. What will be the next step of management in patient conceived when she was taking valproic at a dose more than 1500 per day? Yeah, so someone who already conceived, so you want to look at, I see those patients sometimes. So you want to look at the, as they are there in the first trimester, second trimester, because the side effect, most of the teratogenicity happen in first trimester. Then, at 20 weeks, they can do the anatomical scan and you have better perspective. When they come to you, you talk to them that, this is one of the seizure medications, which more side effect. I'm sorry, unfortunately, you are on this medication. I wish I could change your medication before you're pregnant. But as already, and you discuss with them about the teratogenicity, not to scare them, but you have to be honest to them about what's happening. And you tell them, now, as you are in your first trimester, what we can do, I can try to slowly decrease your valproic acid and introducing another safe one, but we have to go very slow because we don't want you to have seizure when you're pregnant. On top of that, we're also going to have the anatomical scan data, which will also show what are the effect already been, which already happened in the first trimester. So you have to be honest and, work with the patient. I try to switch it slowly, but also anatomical scan is going to show what exactly happened. On third trimester, if they come to you, is there's any point of changing it? And, in third trimester, you'll see it's rapidly change anyway, the drug level. There are very least side effect that occurs in third trimester. So you can just talk to the patient. You already went through the tough time, and the anatomical scan looks good, or the vice versa, whatever. So I guess we can continue it with higher folic acid right now. And if you're still scared of, I'm willing to change it slowly, but that time you have to be very slow and careful during the switching of the medications or transition, or at least lowering the valproic to safer dose, which is 800 to 750. There is a question, a nice talk. Unfortunately, I shall have to leave. Interesting. Okay. Yeah. So I guess, it's very patient dependent. It's more like discussion with the patient and see what's already the damages that occurred on the fetus. And not everybody is going to have, it's not 100% side effect. Some patients will be fine. Now, what other alcohol have for pregnancy and lactation? Anything else? If not, then we'll move to our last topic, which is menopause related issues. Some people with catamanic epilepsy, they count the day when their seizure period will stop, they can get better. But bad news is actually around the time of the menopause, it's going to be very chaotic, and they're going to have a worsening most of the time, or benefit maybe. But there will be a strom in their body, and then they will kind of like go. So it's a bad news for the catamanic patients who are counting their days. But it's reported that menopause, 40% of the women will have worsening of the frequency, which is close to, half of the patient. Whereas 27% go into remission, which is like a hope. So the hormonal changes that happen in the catamanic seizure may increase the perimenopausal and decrease at menopause. So So that was a question from one of the doctors or physicians that what happened to the catamenic epilepsy when they get pregnant, and another question is if anybody want to know what happened to them when they go to menopause. Before menopause, it's going to be very chaotic and they may have worsening of seizure, unfortunately, but it will decrease with menopause. Now, hormone replacement therapy is significantly associated with increased seizure frequency in menopausal women. So you have to, because a lot of the time you may want to give them some estrogen to relieve their perimenopausal symptoms, but that can also make seizures worse. So you have to be aware of that. So the challenges during menopause, other than this, is also you have to be aware of osteoporosis and those damages that can happen from with menopause. That when you have to make sure that it's somebody who is on a drug, who are enzyme inducer, like carbamazepine, dilantin, fosphenytoin, phenytoin, that can actually decrease your vitamin D level and increase the process or exacerbate the osteoporosis. So you want to change those drugs actually before they reach menopause. Like that's what I do for my patients before they reach menopause. If I have a patient who came to me around 45, they don't want to be pregnant, but I talk to them, you're getting closer to your menopause, I would love to change your medications because this is going to cause a lot of problem for you, osteoporosis, fractures. And there are patients, unfortunately, like I remember like months ago, I saw a patient 80 years, so many fractures with so many bad drugs, seizure meds that she shouldn't be on. So there are cases like that, and you wanted to do it, you have to always be active. Before they get pregnant, you want to change it. Before they are on menopause, you want to change it. So you have to be aware of osteoporosis and other effects. Topiramate, there is a study that it can lower the parathyroid hormone, and that's going to cause more bone turnover. So you may not want to use that because topiramate has that alkaline property which increase the bone metabolism. Yeah, so be aware. It's more like it's like a very complex topic. We don't have a very good guideline in any countries. It's just like being more aware of how women are being affected with their hormone at different stage of their life, how it is affecting the seizures, the drugs, educating your patient for that. It's the part of this whole discussion, and it's a complex topic. It will keep on revolving and changing. So it's a topic that you want to keep yourself updated every few months or in at least a year to make sure you know what's the best for your patient. Those are some of my references that I prepare the lecture from, and are from Epilepsia, which is one of the well-established seizure journals that we have in United States, and others are from JAMA articles. Okay, so anything else, any last moment questions that I can answer? Dr. Sultana, do you have any questions? I think I don't hear you. I don't know if you're
yes,
muted.
yes. So you have said that HRT, there is increased risk of seizure, but is it contraindicated to give HRT in menopause because it has a lot of advantages, especially the bone fracture, osteoporosis?
I think it's going to be more about how frequent the seizures are. If somebody has very poor seizures and they have history of catamenic epilepsy, then maybe you would like to try your best to avoid that. But people who don't have catamenic epilepsy and they have no seizures in 20 years, I think the benefit overweight the risk. So I guess there should be no problem. And we run into this situation, which is not very maybe relevant to Bangladesh, but we have a lot of transgender patients here where they are on hormone replacement therapy and they have seizures. So we cancel the same way for them. They have to be on the hormone, and we just tell them you have a little bit of higher risk. See what hormone level is good for you, where you don't get seizures and you get what you want to do. So maybe you can adjust the level and see.
Yes.
Dr. Suchitra, can you hear me?
Yes, I do.
Thank you. It was a lovely talk. Thank you very much. It was extremely erudite. I was just really going to make one comment, really with regards to valproate. It's become increasingly difficult to actually prescribe that in the United. We now have a it's something called a risk assessment that has to be done for every lady with childbearing age. So I think sodium valproate, in terms of its use in epilepsy, is becoming increasingly difficult, really. So I think the role for sodium valproate will continue to reduce as time goes on in the ladies, etc. So that was the only other comment that I was going to make. But thank you for a very erudite discussion. And I regret I've got another meeting I have to attend to, but thank you.
Sure. Yeah, thank you so much. And I would like to thank you everyone for your time. I know it's a night time in Bangladesh. Still you're awake. You want to learn, and you want to help your patients. Thank you so much for all your dedications. And we'll see you again in a few months with more epilepsy related topics.
Dr. Sujita, can you hear me?
Yes, I do. Oh, how are you?
I thought I would have a floor here, so I didn't comment anything.
Oh,
Thank you very much.
Yes, I'm sorry. It's kind of a little bit different right now. And, I also didn't know. I haven't presented anything for a year because of my babies and everything. So I didn't know how it will work.
I'm Professor Dr. Rajiv Chaudhary. I'm a neurologist working as a professor of neurology in National Institute of Neuroscience. We had met earlier during the COVID period, and a nice presentation by you. And you have showed us some issues in Catamania, epilepsy, pregnancy health, and lactation and menopause. One thing you have raised, the carcinogenicity of folic acid. I think it is not accepted at all at this moment. It should be taken at a lower dose. Till now, that is recommended, and pregnancy should be planned. It is not by chance, and preconception folic acid is indicated in our country. And during
what's the dose you use, Dr. Rajiv Chaudhary? What's the dose you are using after the data?
5 milligram per day. Actually, it is written in the book 1 to 4 milligram.
Yeah.
And we are trying to switch to the 1 to 4 milligram. 5 milligram tablet is available here. And the second thing, the choice of drug depends upon the type of epilepsy. As you know, childhood absence epilepsies and other self-limiting epilepsies remit in adulthood. JME is a challenge, and other focal epilepsies needs to address for lifelong anti-epileptic drugs. So the first idea is to target the type of the epilepsy, which one is suitable for the epilepsy, the drug. And as you know that 2 to 3% of the normal mother do have abnormal child with congenital malformations, whereas the women with epilepsy has 5 to 6%, just double. And if they take 3 or more drugs, the chance of teratogenesis is more teratogenicity with sodium valproate. The one issue that one of the doctors told, that if that lady is already on valproic acid and she's pregnant, if she passes the first trimester, she can continue, because she should be followed up with the alpha fetoprotein and ultrasonography. If there is any neural tube defect, then the child should be aborted. With these few things, I'd like to thank for your elaborate and informative lecture. We hope to see that we can share our knowledge and views with you. Thank you very much.
Thank you so much, Dr.
I want to say one thing, that Dr. Rajiv is my classmate. We passed our MBBS from Dhaka Medical College. I am Dr. Luna. Probably he can recognize me or not. I cannot understand. Thank you.
I can. When I saw you speaking well, that's why I remained silent. And told something. Thank you very much.
Yeah, thank you so much, Dr. Rajib. Yeah, it was a little bit confusing. I was thinking, hoping someone else to be here, but
Yeah, Selim Shah was the coordinator here. He's seen to be here, but
হ্যাঁ দাদা
not-
দাদা আমি আছি আমি লাইনে আছি
I should have like maybe talked to
Yeah.
Selim Bhai at the beginning to help with that. Okay, so one thing,
Okay, thank you,
Dr.
Suchita.
Rajib Chaudhary, one thing, I don't know if you missed that part when we were discussing regarding the folic acid recommendation this year. Actually, they have conference in epilepsy, American Epilepsy Society. They have research article proven that high folic acid increase the teratogenicity, fetal teratogenicity, cancer risk. They have more childhood cancer. So now we are actually going back, and we only give 1 milligram folic acid for the newer drugs like levetiracetam, lamotrigine, because those are not proven to require more folic acid. It's more for enzyme inducer. So that will be a good article, new publication if you wanted to read on it. There have been a lot of childhood cancer with women who took high folic acid.
Yeah, this is a practice here to prescribe folic acid to every patient with women with epilepsy having sodium valproate or carbamazepine or phenytoin or everything. Though it's a new information, we are in touch with this and we'll modify our guideline as well.
Yeah, it's kind of like, because there was no study on the newer drugs and everybody was prescribing, including here, we were doing it, but now they wanted to say that actually increase the risk of cancer for the babies. Yeah. Okay, sounds good. Thank you so much, everyone. I hope you have a wonderful night. Thank you for coming once again.
Okay, thank you.
Thank you.
Selim Shahi.
থ্যাংক ইউ দাদা থ্যাংক
Okay. আর কোনো ইন্ট্রোডাকশন দরকার নাই তো নাকি?
দাদা ঠিক আছে
ওকে, কনক্লুড করে দাও। কনক্লুড করে দাও নাকি সেলিম?